Thank you. So, coming to the dissections of the details given, we have a 35-year young male, ACS setting, and he has some risk factors like he is diabetic, hypertensive, and the infarct vessel is a diagonal, it's a branch vessel disease, and it is of 2.5 millimeter caliber, and it is an osteal disease. So, what more we would like to know? So, apart from that, whether he has a markard or not, I would like to know that what is the angle the diagonal is making with the LED, whether a two stent strategy will be possible in this patient or not, because if it is, the angle is bad, and if I end up messing up the LED, then it is not good. And apart from that, I would also like to know his bleeding risk score. Whatever scoring system you use, we would like to know his HB, if he has any renal issues, upper GI bleeds, and thrombocytopenia, any planned surgeries, etc. Because he is acute MI patient, and AMI, as we all know, is an independent predictor of bleeding at 1 year. So we are studying small vessel disease. So how do you define small vessel disease? Any vessel diameter less than 2.8 millimeters is a small vessel disease. And approximately 40 to 50% of all coronary lesions are occurring in small vessels. And around 50% of our coronary interventions are performed for small vessel disease. So much so that we proceduralists have pushed the stent industry to even manufacture 2 millimeter stents now. So why this treatment of small vessel disease is included? Because they are challenging regions. They have higher risk of stenosis and target lesion revascularization. They have higher MACE rates. DES may have longer term issues. We want to avoid DES in small vessels, and so therefore this question of DCB or DEB, whether it can be good as DES. So we have these 4 treatment options, whether we can do a POBA or a BMS or a DES. Now we have even better DES like a biodegradable polymer, no polymer, first generation BVS, second generation BVS, and you can also do a DEB, which I am going to discuss. Apart from this, I'll be very happy if somebody in CardioCon 2024 will be speaking on medical management for this patient, that you coronary plumbers, you just want to fiddle with, put something in it, a stent or a balloon. Why not just medical manage for this osteal branch vessel disease? So because this patient has some restenosis predictors, like he is diabetic, it is a small vessel, it is an osteal lesion, and being an osteal lesion, there can also be a geographic miss. Then you may have to implant another stent, and if the angle is not good, your stent will land into LED, then you will have to do a bifurcation, and you can mess up everything. So now with our considerable decades of knowledge, we know that in-stent restenosis is more common in diabetic, and more so if stent is placed in a small vessel in a diabetic. As you can see, if your vessel size goes on decreasing, your chances of ISR, they go on increasing in a diabetic patient. Why does this happen in diabetics? Because the coronary lesions are more complex in diabetic patients. They have more necrotic core volume and delayed healing secondary to slow endothelization and increased inflammatory response. And this issue was discussed in the morning lectures also. The OCT pictures were shown of uncovered struts. So apart from all the stent issues which are discussed, this uncovered strut issue, many times it is not discussed. So what are the advantages? I have jotted down them together. Because you have a homogeneous drug delivery to the vessel wall, you have immediate drug release without the polymer. This is a DEB is a easily repeatability of the procedure is there, and since there is no foreign object left behind, there is no risk of stent thrombosis, stent embolization, or other stent issues. And it is a shorter depth, so a high bleeding risk patient can be effectively treated. Just last week we had a young alcoholic who came with an anterior wall MI, but he was bleeding on endoscopy done in the midnight. He had varices, and that had to be clipped, and in the morning still the gastroenterologist did not clear us for intervention because he was still bleeding. He wanted to do another colonoscopy and endoscopy, and unfortunately the patient was kept only on medical management. So such high bleeding risk patient, you will need a shorter DAPT, and then a DCB will be a better option. So lower event rates and better long-term safety outcomes and reduced vascular inflammatory response will be there with a DEB, because in absence of any polymer, and potential for allowing the vessel to function normally. Now this last point, it has even been studied. If you see in the top portion a DCB, and a lower slide the DEB DES has been tested for vasomotion by acetylcholine and nitroglycerin, and the portion distal to the stent was behaving had abnormal vasomotion response to the acetylcholine, while was not such the case with the DEB. So coming to the concept of late luminal gain and late luminal loss and luminal gain. So whenever you implant a stent, you have a late luminal loss which occurs, while in the case of DEB, when you implant a DEB, because of the drug, it proliferates into the intima and the media. There is a favorable positive remodeling which happens, and ultimately you get a favorable luminal gain and not a loss. So this has been explained by Dr. Kleber that in a DES there is no vessel enlargement, there is no luminal gain, and there is only luminal loss which occurs because of the neointimal proliferation. While in DEB you can have vessel enlargement and plaque regression, or vessel enlargement only, no plaque regression, and no vessel enlargement and only plaque regression. So these three factors are contributing for a luminal gain in DEB. So this has been studied also that after the treatment with a DEB, you still continue to have a luminal gain in the patients with DEB. So coming to the trial evidence, these are 4 important trials which were done in de novo in small vessel disease, but these were all non-inferiority trial. Now we also have a superiority trial. So Picoletto, Bello, Restore SVD and Basket Small 2, we'll go through them quickly. So in Basket Small 2 trial, some 380 patients were randomized into a DEB and a DES. So at 1 year, it was a non-inferiority trial for MACE, and not only for MACE, even for target vessel revascularization, MI, cardiac death, and MACE, everything was non-inferior, and it continued for even at 3 years, it was non-inferior. So this is Antonio Colombo's slide that if you just take out the diabetic arm in this trial, and if you study them the 3-year results, you see the target vessel revascularization, it is 9% in DCB and it was 15% in DES. So a gross difference in this. So not only in small vessels, a DCB study should be even there in large vessel also diabetics. Coming to the Bello study, same 100 patient, 100 for a DEB and 100 for paclitaxel balloon. So this was a true small vessel study where only 1% of the patient were more than 2.8 millimeter vessel size. So same, it had a non-inferiority for all the outcome, whereas for late luminal loss, it was seen with the paclitaxel stent and not with the balloons. So this is the peculiar slide that shows that on long term it had a superiority outcome, because after 200 days of implantation of the stent, the MACE events, they started to diverge, and the stent related issues, they started after 200 days. So the Restore SVD China trial, they had the 2 arms, a small vessel and a very small vessel arm. In the small vessel arm, they had both the arms, like a balloon arm and the stent arm. And same that at 1 year it was a non-inferior trial. And now, since the presentation of the Restore SVD trial back in 2018, then we had 2 years data in 2020. Now in TCT 2022, they had presented the 5-year outcome showing the same, that it had non-inferior data between both DCB and a DES. So what are these trial taught us? That DEB have same event rates, maintained efficacy and safety as the modern DES in treatment of de novo coronary small vessel disease at 1, 3 and 5 years. And absence of foreign body has a long-term benefit in terms of luminal gain. And rate of both major bleeding and stent thrombosis tend to be lower in DCB than in DES. So coming to the superiority trial, Picoletto 2, in which 100 patients were randomized to a Zion stent and a drug-coated balloon. You can see, as I explained previously also, there is late luminal loss was seen only with the stent. And a superiority outcome was there for MACE and vessel thrombosis. So is it too much to expect better clinical outcome by DCBs versus DEs on the long term, because we have seen a significant amount of trials which I showed? What about our subset of patient, NSTEMI patient who is coming? Can we treat them with a DCB? So this was presented in a peptide NSTEMI trial, in which it had the both arms, a drug coated balloon arm and a DES arm. This trial also showed a non-inferiority data at 9 months. And this trial concluded that treatment of coronary de novo lesions with the balloon, a drug-coated balloon, was non-inferior to the stent treatment. So what for our patients who has a very high bleeding risk score at the presentation? So what for these patients? So a trial was also done, which is the Bout trial. So they had 2 arms, for paclitaxel balloon and a bare metal stent. A bare metal stent because you cannot put a drug-eluting stent for a patient who has a very high bleeding risk score. So this trial also had a very positive outcome when it was compared against the stent. And everybody should go through this paper of drug-coated balloons, where they have dealt with all these trials which I have told, like applicability of DCB in small vessel disease, for high bleeding risk, even for a STEMI patient, NSTEMI patient. So DCBs are now getting applicable in all such patients. Coming to the guideline recommendation, this is the main problem why this debate was kept, because DCBs, there is no indication as on today in an ESC or an ACC for use of DEB in de novo coronary vessel, small coronary vessel. But They are a class 1 indication only for ISR. So till now it is not in the guidelines. That is why this talk has been included. But you just have some position papers by Italian and German and other societies where they have just given some their consensus and recommendations. So what is my experience of using DEB? My experience is at present only with Concept Medical's Magic Tuck sirolimus balloons. So why sirolimus? It is cytostatic and not cytotoxic. We'll see why. It is 1000. It has 10,004 mole safety. It is anti-inflammatory. It has a slower tissue absorption and a short tissue retention. So why why is it cytostatic? Because paclitaxel is acting at the mitotic phase of the cell cycle, and it is irreversibly inhibiting the cell division. While sirolimus, it is binding reversibly to the rapamycin receptors. So this is how the coating is done. The balloon is initially inflated and the spray coating is done. Then it is folded 3 times and then packed so that when we inflate, we have a homogeneous drug delivery. So this is the chart showing on the left side the concentration of the drug coated balloon, the drug in the de novo coronary region, and this is in an ISR. So as you can see, there is a steep decline, and at between 30 to 60 days, the drug absolutely disappears. So this is why 1 month DAPT still you will require if you treat your patient with a DEB. So coming to this, the key for a successful DEB implantation is whether you have prepared your bed optimally or not, because a DEB is designed to deliver an anti-proliferative drug and not to relieve a stenosis like your NC balloons. So this is how your balloon should be applied after a pre-dilatation, 1:1 pre-dilatation. You should assess your angiographic results. If you have no flow limiting dissection like your type A or B dissections, or residual stenosis is less than 30% and an FFR is more than 0.8, then you can still go ahead with a DCB. But for all the other cases, like if you have type C and more dissections, if you have a more residual stenosis, FFR is low, then you should proceed with a DES. So now what if you have used a DCB in your patient and you have a dissection? So what will you do? So this is a study which showed that what happened to the patients who were left with the dissections. At 6 months angiography, 45 of those dissections were healed and only 3 of them were chronic, and they included all the type A, B and C dissections. So we should not be afraid of the dissection. There are many ongoing trials and unavailable data where sirolimus balloons are being compared with paclitaxel balloons and even with giant stents and whatnot. So there are other types of drug coated balloons which are coming up, like they are having stent like profile where they are going to cover the drugs up to 90 days to cover the smooth muscle cell proliferation and migration. So what is the take home? A stent free treatment of CAD with a DEB is a safe, effective alternative of treating side branch ostia, long diffuse lesions, bifurcations in diabetics, and even mid to distal LADs where in future your surgeon might not get upset of putting a graft. So DEB results in significant luminal growth at 6 months, and the key is optimal lesion preparation, and we should not be afraid of dissections. We should not be cosmetologists. We should remain as cardiologists, because if you are I showed you that if you have a type A or B dissection, we should not be afraid and just go ahead and put a stent. And you should have confidence in the DEB, because how will the confidence come? I also had initial hesitancy of using the DEB, because just with practice, start with simple cases and then with the complex cases, and then seeing is believing. So we have come a long way of coronary progress in revascularization, from initially only bypass surgeries to POBA to then BMS, then DES, first generation, second generation, and now we have come to our metal free PCIs with DCB first generation, biovascular scaffolds, and now second generation DCBs with sirolimus and solution SLR, as I was mentioning. So I suggest here is not to choose any one therapy, but a hybrid interventional approach, DCB, and if you have a good result, your non-flow limiting dissections, your FFR is good, your residual stenosis is not much, then you can leave it. If you have those, then you should go ahead and put a DES, because the future is going to be a DCB with a biovascular scaffold or a resorption repair device. So maybe in CardioCon 2024, we'll hear more about resorption repair devices. Thank you.
Thank you. Thank you all. Although it is the debate format, and our opponent is not the Prashant or another, but it is the small vessel disease. So in general, we will be knowing our enemy or opponent, what it is and how it differs from the other vessel, larger vessel disease subset. A brief about our patients, hypertensive and diabetic patients. So already a high risk at the low age. Presentation as a known Osteal lesion MI and lateral wall MI. Treated with the Ticagrelor, and LV function is not mentioned, but I think it should be a mild or normal LV function. Ongoing symptoms, whether a patient is having ongoing chest pain or not, it is not mentioned. And we assume that MI already deep T wave inversions were mentioned. So we expect that MI part is almost over 3-4 hours, and now he is stable. And vitals 100/60, I will consider that not as a hypotension, but maybe he may be normotensive with the medications. And angiography showed a critical osteal stenosis, 15 millimeter, tight in D1. What not mentioned is probably a length of the D1 and length of the LAD, type 3, type 4, type 2 LAD. And the diagonal, which is an osteal disease, runs parallelly as a major diagonal dual LAD, that is not mentioned. So coming to our small vessel disease education or the learning, that how we approach to a small vessel disease. Small vessel disease is present in 30 to 67% of the patient undergoing angioplasty, especially in female patients, in patients with diabetes, and in patient with the chronic renal failure. These are the three subsets in which we found a small vessel disease. The definition of the small vessel disease, when we are discussing about the small vessel, what it is the exact definition? Initially, it started with the 2.8 millimeter and 3 millimeter. And then as the newer devices started coming for the treatment of 2.5 and 2.25, the newer definition came as a 2.25 to 2.5 and ultra small vessel disease also, which is a 2 millimeter and 2.25 millimeter vessel also. All the trials which have been mentioned by the for the drug coating balloon and for the drug eluting stent is having a different criteria cutoff for the 2.25, 2.5 and 3 millimeter. So one trial or second trial cannot be compared in between because the subset is different. All these patients and lesion characteristics, which are the small vessel, diabetic patients, chronic renal failures, and female patient. This is the risk for the device failure, whatever we do. So we have to understand that if we are doing angioplasty with a 3 millimeter, 3.5 millimeter versus 2.25, 2.5, already our patient is at a high risk for the repeat need for the revascularization. Patient with the vessel diameter of more than 2.5, less than 3. And those with the vessel 3 are having a TLF rate 9 versus 5. Significant rate is already there. This we have not reached up to the treatment part. It is in general. So vessel size and long-term outcome. This is what we discussed, right? This is the trial background. Now, some of the facts about the small vessel disease. Remember that whenever there is a small vessel disease, more likely to have a proximal disease. And if the proximal vessels are having small vessel disease, then the distal are also very likely to have. It is usually combination. It is very, very unlikely to have an isolated small vessel disease in the PDA PLE. It will be usually a subset of diffuse disease. The amount of myocardium tributary depends not on the diameter only, but the length of the blood vessel also. Third thing is that true diameter of the vessel we don't know. Sometimes it is the 2.5 millimeter vessel looking like a Sometimes it looks like a 2.5 millimeter vessel, but if you do the coronary imaging, it may turn out to be 2.75 vessel also. And after vasodilatation, when the patient is in MI and you are giving some fluids and nitrates, there could be a vessel not fulfilling the 2.5 mm criteria or small vessel criteria. Accurate assessment of the vessel size depends on the coronary imaging, state of adequate vasodilatation, and relaxation of the patient. None of the study so far discussed by the drug-coated balloon favoring or which I will be discussing, drug eluting stent, is not having any coronary imaging done in the background. So this is the background of the small vessel disease, that how the trials are analyzed. Now coming to the study data, the contemporary second generation DASH showed an outstanding performance in the patient with the small vessel CAT. When we say small vessel, it is around 2.75, 2.5 and 2.25 and 2 millimeter. Great number of dedicated studies, subgroup analysis of the large randomized studies. New generation DASH reduced both late lumen loss and the clinical restenosis. This was seen even in the small vessels that tolerate late lumen loss less well than the larger vessels. In addition, the rate of death, MI, stent thrombosis were low, which underline the safety of these devices. I will show the data. So this is the trial 3 millimeter, the same trial basket trial, which was having an arm of the drug-coated balloon also, basket small trial. Then this is for the 3 millimeter vessel. Now 2.75 bioflow, leaders and the Olivera. So we are coming to the another trial, 2.25 data, less than 2.25 data. So we are having a 70, 835 and 101 patients for the less than 2.25 patients. And we can see the TLR in the range of 4, 6 and 2. TLR is quite low. If I will go back to previous slide, see the data of 2.75, 1300, 800, 1300 patient sample size with the vessel size of 2.75. Now coming to the 2.5 millimeter size data. This is the size which our patient is having. And see the number of sample size, 1500, 1600, 1900 patients, and see the TLR rate ranges from 3% to the 4% to 5% only. And these are the follow-up of 2 to 3 months. All the patients are having DAPT follow-up for 6 months. So this number of trials shows that we are having a single digit less than 5% TLR and TLF with the 6 to 12 months of DAPT with the available stents. These are the dedicated small stent registries, trials, not registries, sorry. So result is due to what? Why this result came? The result is because of the strut thickness. Osteal versus Zane's bioscience studies and bioflow studies and bioresult. These are the polymer-free stents with the 60 micron strut thickness, and the cell design like Resolute is also developed in such a way that it is single wire coiled or laser fused devices, which will reduce the need for the polymer, and chances of restenosis, late lumen loss and stent thrombosis will be significantly less. A number of studies suggest that the patient with the diabetes and small vessel disease could benefit the most from the use of drug-coated balloon instead of drug-eluting stent. Yes, I am telling about the drug-coated balloon. Which trials? Basket, Small 2 and Bellow, which our Prashant described. But what they have written, just I will write down. The use of drug-coated balloon in de novo lesions, which are not appealing for the implantation. For the stent, represents a growing indication. Number one, the use of DCB in anatomic setting adverse for treatment with the DES was only shown to be similarly efficacious. So this is the statement given by them. Now coming to the trials of the drug-coated balloon. These are the trials for the less than 3 millimeter, less than 2.75 millimeter and less than 2.5. See the number of slides available, number of trials available, only 4 to 8. Number one. See the sample size. Sample size is 700, 100, 57, 230 and 101. These are the data for the vessel size included for 3 and 2.75. For 2.5 we are having only one trial. So Bellow, Basket and Piccoletto doesn't apply here because it is for 3 and 2.75, not for 2.5, which is there. Estimation, TLR rate and TVR rate. See the rate 6, 5, 32, 5, 5, 4. TVR rate 32, 10 and 5.3, significantly high as compared to what we have seen even for the 2.25 and 2.5 in the stent studies. So what are the limitations of the data, including DCB or DEV? What are the limitations? Number one, what we described initially, diameter was assessed in a different ways. Some trial had a QCA, some trial had a visual estimate. Number one, range from the visual assessment to QCA. None of the study used any imaging or the coronary, and very limited head-to-head comparison data. None of the trial had a head-to-head comparison data. So last comparison trial, we are having only, I could find only one comparison trial, which was a head-to-head trial. Percutaneous treatment and outcome of small coronary visit, SCAR report. This is basically see the number of patients. The aim of the study was to investigate the outcome of patients with de novo lesions in the small coronary vessels undergoing PCI with the DCB or the new generation DES. Methods. 2009 to 2017 patients. Number one, vessel size is less than or equal to 2.5 millimeter. What are the number of patients analyzed? 14,788. It's almost 15,000 patients data. With the drug-coated balloon, 1,154. Very high number of DCB. 13,000 patients with the 2.5 millimeter size stent. 13,000 patients. Okay. The propensity score, see the data, you can read. What is the conclusion? Conclusion is that because of the significant higher risk for the restenosis, I am reading the restenosis up to 3 years. This research suggests that a DCB are not an equally effective alternative to newer generation DES for PCI of the small coronary vessels. This is the flow chart of the patients, how they were included. All patients with the small vessel CAD who underwent PCI were enrolled, and then restenotic lesions, BMS, all generation DES, they were excluded, and then a head-to-head analysis was done. This was the curve Kaplan-Meier, And we can see that within first year, both the curve started separating for the DCB versus the drug-eluting stent. Procedural characteristics. Now this is very important. See, it is not a diagonal vessel. See, it is for the LAD, LCX, and left main. It was not for the small vessel disease of the OM or the PDA or PLV. These are the main blood vessels. Number one. Number two. See the bifurcation. 228 versus the 1600. The p-value less than 0.01. See the number of devices 2. See the type B2 and type C lesions. P-value was significant. So I am telling, even in bifurcation, even in complex lesions, even in the main coronary artery, not in the branch vessels, we are having a better result with the drug-eluting stent, which is of newer generation, when the vessel size is of 2.5. This is the favoring DES versus favoring DCB in the different subsets, in the age, in the diabetes, whether bifurcation, whether presenting with the ACS, or whether having a complex lesion. So with this enough information, our management strategy is clear that it should be a drug-eluting stent. It should be a newer generation drug-eluting stent dedicated for these small vessels. And how to approach. This is not related to this our patient, but in general, how we will. Number one, we will give the nitrate. We will go for the coronary imaging if possible. We will assess the length of the blood vessel, expected myocardium under threat. We will remember that small LAD is different than the small vessel OM or distal PDA PLV. Long lesion in the small vessel versus short lesion in the small vessel. Both are different. If we are having a small vessel, but this lesion is very long, where I am putting a 2.25, 2.5 stent, which is of 38 or 48 millimeter, I will differ. I will go for the drug-coated balloon. But if I am having a 2.5 millimeter diameter with a lesion of only 15 millimeter, I may go for the stent. Expect higher chances of restenosis. Start with a gentle POBA, see the response, flow-mediated vasodilation, and then decide. See for the dissection also. Choose dedicated stents, and drug-eluting balloon reserved for small, long lesions in the branches, that is 2.25 or 2 millimeter, where we think that, okay, medical management or doing something is equal. This is the main pitfall of the trials, small vessel disease. What is it? Do the POBA. If there is any dissection or restenosis, yes, then go for the registry, not the trial. And what trials were shown, this Piccoletto, Bello, Basket Small, is a 2010 trials. It was with the paclitaxel, not with the sirolimus, which is available right now. And the number of patients were less. And we can see, they have not highlighted, 20% of the patients in the trial had a stenting done. They were posted for the drug-coated balloon arm. They went for the drug-coated balloon, and 20% of the patients went for the stenting. So these were deviating the results. So this is again the same. We can see that 10, 19 and 19% went for the DES BMS. Pepcade, I'm not, or ISAR China, I'm not going into the detail because it was the restenotic trials. And our patient is not having a restenosis, it is a de novo lesions. So restore SVD also I'm not going in the detail because the dropout rate or the bailout stand rate is not mentioned in that. So this is the case. I think that should be sufficient for us to have a